Lane. Thanks everybody. Thanks everybody for having me and let me talk to you guys. I'm gonna just give a brief overview of common things that I see in my office, common things that affect our feet and ankles, particularly as we get older. And I hope that all of you can take away something practical. I think you'll realize a lot of what I do is non-surgical, and involves, footwear modifications, activity modification, non-surgical treatments. And so I hope you learned something, and I encourage anybody to ask questions, and I'm happy to answer anything at the end of the presentation. And I guess we'll get started. So just a little bit about me, maybe. There we go. Okay, so my name is Cole McGregor. I'm an orthopedic foot and ankle surgeon with Ortho Kansas here in Lawrence. I've been in practice now for a year, and have gone through training. So I'm from Liberty, Missouri originally. Grew up there and went to undergrad at University of Kansas, medical school at the University of Kansas, and then I went to Chicago for 5 years for my orthopedic residency at Loyola University Medical Center in the west suburbs of Chicago, and then went to fellowship for complex foot and ankle reconstruction at the Campbell Clinic, which is in Memphis, Tennessee. And then now again, I'm here in Lawrence and seeing patients and really enjoying it. My wife and I are here. We have 3 kids with another one on the way. So we're really enjoying Lawrence, and the practice has been great. And so we love it here. So my scope of practice, just a brief overview, involves basically anything involving the foot and ankle. So that's trauma, deformity, sports injuries, overuse injuries, bunions, hammer toes, anything that affects the foot and ankle is in my purview and scope of practice. And a lot of the things I'll focus on today deal with degenerative conditions and kind of overuse type things. But just for an understanding of the broader scope, it does involve everything. So we'll start with ankle arthritis. It's actually one of the more rare arthritides of the foot and ankle, but it most commonly affects those who have had trauma to their ankle, a fracture in the past, or an injury of some sort, chronic instability that leads to abnormal forces across the ankle joint. And so you can see an image on the top there of a nice two kind of convex and concave surfaces that match one another nicely, and there's joint space there. And then you see the bottom right photo where there's really no joint space whatsoever. You start to get spurs on the ankle joint, and this becomes very painful. And so you're going to realize that a lot of the non-surgical options we use are applicable to all of these problems. And so for ankle arthritis in particular, custom or off-the-shelf braces can be useful. Oral anti-inflammatories like ibuprofen type medications, and those include topical medications as well. Injections into the ankle joint of steroid can be helpful, and physical therapy. And then surgical treatments for these, we used to always fuse ankles, and ankle replacement was not really a great surgery back in the 80s and 90s. However, technological advancements have really done great strides for total ankle replacement, and it's now a very viable option for patients, for the right patient. And some benefits of total ankle in comparison with ankle fusion are it's a motion sparing procedure, meaning your ankle still move, whereas if you fuse your ankle, it's fused in the position that it's in, and theoretically is in that position forever, ideally. Total ankle replacements, they can wear out with time and require further surgery, but we have data to suggest that over 90% of patients still have their total ankle in and have not required a second surgery after 10 years. We don't have data out to the 25, 30, 40 years that total hip does, but it's still a very good operation, and outcomes are continuing to improve. And patients do better with a total ankle. Their function is better. They do not get what's called adjacent joint arthritis that you see on the ankle fusion column. Whenever you fuse a joint anywhere in the body, that force and stress has to go somewhere, and oftentimes it affects the joint above and below the joint that's fused most commonly, and those joints are more likely to get arthritis. And so we found that total ankle is preferable for this if we can in the right patient. There are reasons why we can't do it, neuropathy being the most common one, but it's a very good operation that's seen very significant advancements. Midfoot arthritis. So the midfoot are the joints kind of across the bridge of your foot. And there's many causes of midfoot arthritis, but there is a clear correlation with obesity and weight. The more weight we have on our body, the more forces we have through our midfoot. And this is a very important part of our foot for gait. Women are more affected than men. We don't really know why that is, but it's definitely the case in my clinic. I see a lot more women with this problem than men. And painful spurs develop on the top of the foot. And I think that picture nicely illustrates that. These are in a very prominent area and they rub on our shoes and they become very bothersome to a lot of patients. And in some cases, we can just go and take those spurs off. In other cases, the arthritis is so advanced that we need to talk about doing other surgeries for that. And you can see that can become a very painful sight. So treatments for midfoot arthritis, non-surgical shoe modifications. I'll talk about some of those in the following slides. Inserts for your shoes. And again, that'll be on the next slide. A midfoot sleeve can be helpful, which is a tight brace that goes across your midfoot region to kind of prevent some of the friction that occurs when you wear shoes or if you have straps on your shoes that rub that area. Oral anti-inflammatories, which are a mainstay of all these treatments, topical medications, whether that's over-the-counter anti-inflammatory creams or prescription compounded creams that are made at special pharmacies, physical therapy, and finally injections of steroid, once again, can be helpful. And then surgery for this often involves either newer treatment involves a neurectomy, which is where we actually go in and remove the nerve that innervates the painful joints and that can alleviate the pain. It does not fix the fusion or does not fix the arthritis like a fusion does, but it does take away the pain. And then a fusion procedure is where we take two bones that don't normally live with one another and we actually fuse them to each other using hardware. And that surgery is kind of the gold standard for midfoot arthritis that we've been doing for decades. And then some of these shoe wear modifications for midfoot arthritis. So if you have top of the foot pain or kind of bridge of the foot on the top, then these can be very helpful. And you can see modified shoe lacing on the left there is where you cross your laces at the bottom, you run them up the sides in the middle, and then you cross them at the top. And that can leave you this window of space where the laces are not pressing against those bony prominences and can give you some relief from pain when you're wearing shoes. A lot of my patients say, you know, it actually feels fine when I'm sitting down, not walking around, but then when I put shoes on, it really irritates those spurs or the arthritis. Carbon fiber inserts, and you're going to see these throughout a few different of the slides. These can be very helpful for anything where chronic bending of the foot affects you. So big toe arthritis, midfoot arthritis, whenever there's kind of a lever arm when we're walking, the carbon fiber is very rigid and it can provide some shielding of the joints from those forces and it can take some of the forces away and prevent some of the pain that you have. And you can see this is that area of kind of open where you don't have as much pressure. Rocker bottom shoes can be helpful for midfoot arthritis. You can see how there's a gentle curve here to the shoe, and that can be helpful for patients that have midfoot arthritis because the shoe kind of does some of the work for you that you previously had to use, your midfoot to propel you to the next step. The next problem that's very, very common, maybe the most common thing I see in my clinic is pain in the ball of the foot, and the medical term for this is metatarsalgia. And metatarsalgia occurs right at the heads of our metatarsals. So our metatarsals are the long bones in our foot. And pain at the heads of those bones is the area that we call metatarsalgia. Why does metatarsalgia occur? Almost unanimously, it's because people have tight calves. And many of us have tight calves, especially as we get older and we become less active. In many cases, our calves get tight and those forces get transferred to the front of our foot when we walk. And metatarsalgia is something that rarely needs surgery. It's very responsive to stretching. You can see some common stretches that I recommend here. One is a stair stretch on the top left there, where you let your heel drop off the stair and really stretch the back of your calf. And then other forms of the same kind of stretch against the wall, putting your foot up against the wall or actually pressing up against the wall, kind of like a runner's stretch. But there are, specialized devices and inserts that can also be helpful. And I'll talk about some of those on next slides as well. So the three rockers of gait, without getting in the weeds of gait biomechanics, but there's three rockers to our gait, and this starts with the heel rocker, with our heel striking the ground and slowly dropping our foot down to the ground to be a foot flat position. The ankle rocker, where our foot is flat throughout that entire rocker of gait. And then the final rocker where we go up onto the front of our foot. And many patients say that this third rocker is when they really start to feel pain in the front of their foot because this is when 4 to 5 times our body weight is transmitted through these tiny little bones in our foot. And so as our calf gets tighter, it actually transmits a lot of the force into the front of our foot when it's not flexible. So the sooner that you lift up onto the front of your foot in your gait cycle, the more force is going through your bones, and resultantly, the more pain that you can have. So I'm trying to describe why keeping your calf flexible is very important for front of the foot pain. It's not the most intuitive thing until you kind of understand these three rockers of gait. The more flexible your calf, the less force is in the front of your foot. And so some simple things you can do for metatarsalgia, a metatarsal pad or metatarsal cookie, and that is on the left-hand side. It's a teardrop shaped piece of felt or foam that goes in your shoe or it goes on the insert of your shoe, and it sits right behind the area of pain. I see a lot of patients that come in and they've gotten the right device for their pain, but they're not using it correctly. They're actually putting it right underneath the pain, and that's not how these are instructed to be used. They really are designed to lift up that area of pain. And then on the right-hand side is a metatarsal bar, which is better for diffuse pain in the forefoot, pain that affects, 2, 3, 4, and 5, and can be really useful for those patients that have that pain. So these are very common, and I probably hand out, 2 or 3 of these per clinic in the office. Lesser toe deformities include hammer toes most commonly, and those are the ones I'll focus on today. These are chronic deformities. They often occur in concert with metatarsalgia. So as our toes hammer and kind of claw, we actually create more pressure and prominence of our metatarsal heads. And going back to metatarsalgia, we know that can cause pain in that area. And accommodation is key. So there's not a ton of non-surgical options for this. Things you can try would be roomy, wide toe box shoes, something called a boot and splint, or a hammer toe crest pad. And I have some pictures of those on the next slide for your reference. And then finally, surgical options. And most commonly, that just means a hammer toe correction. And that can be done in a multitude of ways. Sometimes I do it with a screw, sometimes I do it with a wire. Sometimes we do it open, and sometimes we do it in a minimally invasive fashion. And that can be a good option for many patients to straighten the toes. These are some simple devices you can get on Amazon for hammer toes. And they really are for two separate purposes. And I want to make sure you guys understand what each one does. The one on the left, the button splint, is made primarily to keep the toes relatively straighter. If you have flexible hammer toe deformities, if you can take your hand and straighten your toe out, the button splint can be helpful. And it can help to splint the toes together and help them from elevating or causing prominence or irritation on the top of the shoe. On the right-hand side is a hammer toe crest pad, and that's more for rigid deformities that you cannot passively correct or passively straighten. And it's for tip of the toe pain. So many times when we hammer our toes, going back to this picture, you can see this patient is actually walking on and putting pressure on the very tip of the toe. And that's really not how our toes are meant to be loaded. There's a nice soft pulp on the bottom of our toe that's meant to touch the ground. The tips are not. This hammer toe crest pad aims to lift up the tips of the toes so that they're not in contact with the floor, and this pad takes some of that pressure off. Big toe arthritis, another very common problem. Many patients have it on x-ray and are asymptomatic. We don't really know why that happens. You can have, horrible arthritis on x-ray and minimal symptoms, and you can have mild arthritis on x-ray and have horrible symptoms. So we don't quite have that figured out as to why that is, but it's certainly a common problem that happens with the foot and ankle as we get older. Non-surgical methods, shoe modifications, carbon fiber inserts, oral anti-inflammatories, topical medications, physical therapy injections. You should recognize that from some of the other slides. These are very similar to some of the other problems we've talked about in terms of the non-surgical methods. And then surgical methods include a cheilectomy or a fusion. And a cheilectomy is a specialized procedure where I actually did one today, where we open the joint. We actually shave off with a saw the prominent painful spurs to increase the range of motion of the toe and reduce pain. And then a fusion. And a fusion is where we fuse your metatarsal to your phalanx, and that is the two bones of your big toe joint. So you do lose motion with the fusion. Patients are still able to return to walking, tennis, golf, sports. Many patients go back to those kind of things after a big toe fusion. The only things I tell patients you can't get back to are telemark skiing and some yoga poses. Any yoga pose where your big toe is really wrenched backwards and extended can cause this problem. I do not recommend joint resurfacing or replacement for the big toe. The literature and the research on these, they show poor durability. There's a high complication rate. There are some surgeons out there doing them, but it's not something that I typically do or recommend because the scientific data behind them is just not robust enough to recommend them. Maybe someday the technology will get there, but we're not at that point, in my opinion. So here is a chilectomy on the left where you can see those painful bone spurs that are pinching against one another. We go in and take those off, and patients do quite well with that surgery. And it's a motion sparing procedure, meaning you're still able to move your big toe after that's done. And then on the right is a big toe fusion. You can see a plate and screws. We fuse those two joints together, and ideally, it takes about 10 to 12 weeks for that to fully fuse. In some cases, it takes longer, and we're delayed in that healing, but that is kind of the gold standard for big toe arthritis that's not responsive to non-surgical methods. Bunions. Bunions are also a very common thing that come into my office, and I think they're poorly understood. And a lot of my patients are getting direct to patient marketing, meaning, there's certain companies that are skipping advertising to healthcare professionals and they're going straight to the patients and saying, you need to have this surgery. And everyone does great, and you're able to walk out of the office the same day as the surgery. And a lot of those claims are not necessarily true. And so I get a lot of misinformation in my office about bunions. And, if you have a bunion, it is not inherently a problem unless it bothers you. If you have pain, if you've tried multiple different shoes and you can't find anything that gives you relief, you're miserable, and it's something you think about or bothers you every single day, that's a bunion that needs to at least discuss options. If you have a bunion and you never think about it other than maybe once or twice a month when you overdo it, that's not necessarily a bunion that needs surgery. And what is a bunion? A bunion is basically a malalignment of the first ray or the big toe joint, and it actually can be caused by instability higher up in the middle of the foot. It can be caused by trauma. It can be exacerbated by footwear. We know that many bunions are congenital in nature or hereditary in nature. If mom or grandma has a bunion, you are much more likely to have a bunion yourself. And, we used to think, oh, well, it's because of all these narrow shoes people wear. And that's not necessarily the case. We have some societies in, third world countries where they don't really even wear shoes, or they wear sandals that never press on the big toe, and they still have patients with bunions. And so that's kind of been debunked.
Hmm.
And you can see here, this is, kind of a good illustration of on the left-hand side, a narrow shoe where the bunion is really symptomatic and bothersome. It's a leather kind of buck shoe, and it does not accommodate very well. It doesn't provide room for that bunion. And then one on the right that has a wider toe box. It's made in a more anatomic shape, and it really accommodates that deformity better. The medical term for bunions is hallux valgus. So if you see that term, those are synonymous. Non-surgical treatment includes wide toe box footwear, like we just discussed, and then bunion spacers or guards. And this is one that I like on the bottom left. It's called a NatraCare bunion guard, and it's made of silicone. It has a spacer in the first web space, and then it has this guard that protects the medial eminence. And, unfortunately for bunions, I tell patients there's kind of a short runway of treatments that are non-surgical. And so we don't have a multitude of different things. I don't think physical therapy is helpful for these. Injections are not helpful. Oral anti-inflammatories are intermittently helpful if there's irritation of the medial eminence or that really prominent area, but we don't have a ton of good treatments that are definitive and that will give you relief. And so in many cases, patients that come in with symptomatic painful bunions that they're really sick of, we talk about surgery, and that can involve many different options. There's over 200 different described procedures for bunions. And so there's a lot of different ways to skin a cat. And so that can include a Lapidus fusion, which is a fusion of the first tarsal metatarsal joint or higher up in the foot. And that in many, you guys might have heard of Lapiplasty. That's the one that is doing a lot of the direct to patient marketing. And I have patients come in that say, well, I've been told I need a Lapiplasty. And in some cases, that's true. And in other cases, I think that's too much surgery for some of these patients. And so I think the thing I want you guys to take away is, speak to a professional, speak to an expert in whatever, area that you're looking into before you get convinced that you need one surgery or another, because a lot of these companies are incentivized to have patients think they need the surgery that they're selling. And I think as things progress and more companies go to that direct to patient marketing, it's going to be really important that we get information from reputable, credible sources. And so that's just kind of an aside, but so many different options for bunions: Lapidus fusion, minimally invasive bunion correction, which is a common thing that I do, and we'll talk a little bit more about minimally invasive surgery, but that's done through small keyhole incisions. It's something I have specialty training on, and we do it for bunions. We do it for hammer toes. We do it for metatarsalgia that doesn't respond to non-operative treatment. So there's a lot of different minimally invasive surgeries out there. And then finally, osteotomies. So that can be many, many different osteotomies. If you look online, there's a ton. And that means cutting bones. Osteotomy is a simple term for a bone cut. Minimally invasive surgery, like I said, these are innovative techniques to perform foot and ankle surgery. It's a newer technique that we've been doing for the last 10 to 15 years, probably. And really in the last 5 to 10, it's become much more prevalent and accepted, and we've we have good literature to show that patients do very well with that. So it's done through small keyholes. We don't have to make big incisions. So this is an example of a minimally invasive bunion correction. On the top, you can see the clinical photo and the X-ray demonstrating a bunion. There's angulation there of that joint. And then the bottom is the foot after it's been corrected with a minimally invasive surgery, done through small poke holes, and screws are inserted through the small incisions to correct the deformity. Patients have less pain with this. We have very good rates of deformity correction and low rates of recurrence. Less opioid pain medication is needed after these in comparison with open bunion procedures. And they're gaining popularity and acceptance. Each year I feel like more and more people are doing this. So how can you optimize your foot health? And I think that in broad strokes, weight management is critical because the foot is unique to other joints in our body in that we put so much of our body weight through them, and 4 to 5 times our body weight with each step. And so the less load we put through our feet, the more they're going to stand up over time. Supportive footwear. I think that's something we've kind of hammered home throughout this presentation is the shoes that you choose to wear are critically important, especially as your foot starts to become have deformity or have arthritis or changes in shape. It's important that your footwear changes with that. And I think also making sure that you're updating your footwear. Like if you haven't gotten new tennis shoes or shoes in general in over a year, it's probably time to think about looking at getting some new because they certainly do wear out. Maintaining strength and mobility. This is a generic statement that we hear all the time about everything with our health, but I think it's critical, and I think that it bears mentioning. There is something, the American Orthopedic Foot and Ankle Society is the society that I'm a member of and that all foot and ankle orthopedic surgeons are involved with. And it has great resources for patients. And Foot Care MD is that website. If you're thinking about having a surgery or if you have a problem with your foot and you want to learn more information, it's a very good, reputable source to go to. And it's non-biased. There's no industry involvement. There's no sort of back channeling of certain companies promoting anything. It's purely just educational material. And maintaining strength and mobility in particular, there on that website, there's an AOFAS foot and ankle conditioning program, and I hand that to a lot of my patients that are looking for just a general program to do to keep their foot and ankle healthy. And there's about 12 to 15 exercises in that packet, focus on anything from calf stretching to intrinsic small muscles of the foot, keeping those strong. And then patients ask me what supplements can I take, and there's not a ton of good data on supplements because they're not regulated by the FDA, but we know for certain that calcium and vitamin D are important for bone health. So I'd encourage you to talk to your primary care doctor about starting those and an acceptable dose for you. Postmenopausal women in particular, vitamin D is very important, and I think it's something that people should strongly consider being on for bone health, especially if you're going to have any sort of bone surgery done. And then for neuropathy, a lot of my patients have neuropathy as a result of diabetes or idiopathic neuropathy, meaning neuropathy we don't know why. And a B vitamin complex can be helpful for that. So shoes, rules of thumb for shoes. Make sure they're appropriate size, and that doesn't just mean length, also width. So if you see on the tongue of your shoe, the standard sizing is a D. So if you have a size 9 shoe, a 9D is a 9 length, and a D is a standard width. And then wide is an E, and a double E is extra wide. So if you have a bunion or a bunionette, which is a prominence on the outside of your foot, or you just have wide feet in general, you really should be getting wide or extra wide shoes to allow room for that. And then supportive shoes. I call this the toe to lace test. Any of your tennis shoes, if you have foot pain, any of your tennis shoes or shoes in general that you can take the toe and touch it to the tongue or touch it to the laces, I call it toe to lace, that's probably not a good shoe for you. It's if you can wring it out like a towel, like this, it's probably not a good shoe for you. You need to have supportive shoes that stand up to the wear and tear that we put our bodies on. And then just some quick kind of wear this, not that. So flip-flops, if you wear these kind of Old Navy, kind of really floppy, non-supportive flip-flops and you're looking for something else, FitFlops is a great. And I don't receive any royalties or anything from this. These are just companies that over the years I have found my patients like for more supportive shoes. So not standard flip-flops or thongs. FitFlops are nice. They do have some arch support ones. They're more supportive and robust. Tennis shoes. A lot of my patients come in with Skechers because they've been told, oh, well, they are supposed to be good for your foot. Many Skechers are really, really floppy. They're not very supportive. You can wring them out like a towel, you can bend them, and they're just not robust enough to support your foot. And I find that, in particular, a lot of my patients like this Brooks Adrenaline GTS or the Brooks Glycerin. I personally wear Hokas, and a lot of my patients like Hokas. They're a little bulky for some people. They feel like they're too far off the ground. But Brooks, Hoka, Asics, all of those companies can be helpful and can be good shoes for you. Sandals, I'm a huge fan of Birkenstocks. A lot of strappy kind of leather sandals have absolutely no support. You're basically just walking on a, 5 millimeter piece of leather. And a Birkenstock has almost an orthotic built into it. And they can be uncomfortable at first because you have to wear them in, but they're made of cork and leather and they accommodate to your foot and they almost become like customized to you with time and wear. So I'm a huge fan of Birkenstocks and they are rigid and they're supportive. Barefoot shoes, these are kind of the bane of my existence, particularly these Hey Dudes. I see a lot of patients walk in with these, and they're some of my least favorites for patients because they're just not, they feel good because they're very soft, but they have no support. And if you're looking for an easy to put on shoe, or a shoe that, feels like you're kind of not wearing a shoe, this Kizik company can be nice. And the way the Kiziks are marketed as you can put your foot in them, you don't have to bend down or use a shoehorn. You can just slide your foot right into them. Even the ones that are closed-toed, or closed on the back, you can just put your foot into, and they have some tennis shoe options as well. So when is it time to see a surgeon? I think when you've failed non-operative management, you've tried physical therapy, you've tried medications, you've tried braces, you've tried shoe wear changes, and nothing really seems to be helping. And, acute injuries that do not resolve or worsen. Obviously, if you have something occur where it's very clear that something serious is going on, then we want to see you and we want to help you. And then referral from primary care physician. You don't always need a referral. You can refer yourself. You can call our office and say, hey, I have a problem and we're happy to see you. But I think if your primary care doctor has exhausted what they know how to do for your problem and you're still having issues, I think it's time to see a specialist. So again, come and see us. This is our office phone number. I'm happy to see, anybody, and I hope that we can help you. I hope you've learned something from this presentation, and I'm happy to answer any questions as well. You can follow my practice on Instagram, Kansas_foot. And thanks again for letting me talk to you guys. It's been great. Thank you.
Great. Thank you so much. That was a lot of great information. We do have a few questions in the chat, and so I'll just read
Okay.
those. And the first one is, I guess, more of a comment, but maybe you can comment on it. From Pam, I have a torn tendon in my foot according to an MRI, and she actually has an appointment with you next
Okay.
week. It bothers me and then doesn't and then does again. So I finally decided to have it looked at. Do you have
Yep.
any tips for
Yeah, I
torn
mean, I think this is a
tendons?
great kind of segue back to when is it time to see
Hmm.
a specialist. And I think that when it's something that keeps coming back and it's not resolving, then this is definitely a situation where I think I can be helpful. And I look forward to seeing you. We'll look at your MRI, we'll review it, and we'll talk on the 29th.
All right. Kind of a pre-introduction there.
Yeah, there we go.
Another one, I had very painful plantar fasciitis that I cured, quote unquote, with stretching and shoe inserts. Could I have avoided all this by being more active?
Yeah, and I plantar fasciitis is also a super common thing I see in my office. I could have given a 45-minute talk on just plantar fasciitis, but I would tell you that no, you can be the most active person in the world and you can still get plantar fasciitis. And we don't, plantar fasciitis is one of those frustrating things for the patient and for me because we can do all the right things and it can still kind of rear its ugly head and be one of those things that really is hard to get rid of. Stretching is important and it is been shown to be just as effective as a formal physical therapy regimen. And I think that plantar fascia stretches, I give patients handouts on plantar fascia stretches all the time for this problem, and it is helpful. It doesn't fix them all. And other things that I recommend for plantar fasciitis are, rolling with the frozen water bottle, like a plastic water bottle that you put in the freezer, rolling on that and really working out that scar tissue and inflammation. And shoe inserts can be helpful, certainly like a heel cup, like a gel heel cup. In some cases, plantar fasciitis is again related to tight calves because all of that plantar fascia is connected to our Achilles and our gastrocnemius, which is our big calf muscle. And if that's tight, the plantar fascia is tight. And so sometimes, all these things don't work, and we have to talk about more invasive or more aggressive modalities, and that can include radiation actually with low dose radiation to plantar fascia has been shown to be helpful and PRP, which is a platelet-rich plasma, which is when they take your own blood, spin it down to some of the anti-inflammatory components of blood, and they inject that into your heel. And then finally, if those things don't work, then we're talking about procedures like a surgical procedure, and there's some on the market like a tendon debrider that's done through a small poke hole, and they are able to clean up that inflamed tissue. But all that's to say, to answer your question, you could not have avoided it probably. This is probably something that was bound to happen regardless. And I think that the fact that you're able to get rid of it is great because some of my patients are not.
Okay. Great. The questions are rolling in now. From Gary regarding the width of feet. What if you
Yeah.
have narrow feet? D is too wide?
Yeah. So there are some companies on the market that are just inherently more narrow. And I find that Nike in particular is
Mhm.
a company where their standard is more narrow than other companies' standard. And so that's sometimes a shoe that I recommend for those patients. And then also, many patients that have narrow feet also have concomitant other deformities that we can recommend some inserts for, off the shelf inserts that are 40, $50 online that can be helpful, that can make your shoe that is somewhat too wide not feel like it's so roomy, if that makes sense.
Yeah. From Diana, what causes foot cramps?
Yeah, Diana, I would say the most common thing I see is some degree of neuropathy. And I don't know your situation, obviously, but in many cases, foot cramping, particularly at night, is related to neuropathy. And it can also be related to a degree of inactivity. Keeping our muscles strong helps them not spasm and cramp.
Okay. And Rebecca says, I'm guessing you're not a fan of Zero brand shoes.
Zero are kind of a barefoot shoe. There's zero drop, and we didn't get into drop, but drop is basically how does the shoe incline from the heel to the toe?
Mhm.
And the zero brand shoes, many of them are zero drop, so they're the same height in the heel as they are in the toe. And I think if you have a normal foot and you don't have plantar fasciitis, you don't have tight calves, and you have what I call a plantigrade foot, and plantigrade means it's shaped normally and it sits normally on the floor. I think a zero brand shoe is perfectly fine. And if you feel good in it, That's what I always tell patients is if you feel good in it and it's working for you, that's totally fine with me. So I'm not going to have a blanket statement that I don't like them. It's just they're not right for some patients.
Okay. From Charlie, do you have any options for neuropathy?
Neuropathy is hard. It's a problem. It's a difficult problem that I don't have any surgical solutions for, and it's a frustrating problem for the patient because there's not great options. Some patients use prescription medications, such as gabapentin or pregabalin. However, those medications do have side effects, and obviously, it's another pill to take, which a lot of patients are like, "I'm tired of taking pills." Like I said, a B vitamin complex can be helpful for neuropathy. It helps us maintain nerve health. B vitamins are critical for proper nerve function. And in many cases, we get those through our diet. But if you don't, or you want to supplement that, then a B vitamin complex can be helpful. But no, there's not really any definitive fixes for neuropathy. Once you have neuropathy, unfortunately, that's something you just have to learn to deal with in a way, which is not the answer that I like to give patients, but it's true for neuropathy.
Okay. Here is one from Jan. Can you get arthritis slash pain in just one toe? And then she comments, admittedly, a toe I probably broke about 20 years ago. If so, is there possible treatment?
Yes, there absolutely is treatment, and it is certainly possible to get arthritis in one toe, especially in a post-traumatic setting. It kind of depends on what toe it is. If it's the big toe, the treatment's different than a lesser toe. And there's, a lot of different things that go into making a determination of what we feel like the best surgical treatment is. But there's absolutely treatments for that. And it
Okay.
depends on what your x-ray looks like, what your foot shape is, all of these things.
Okay. And then Alex asks, do you have any tips for frequent muscle cramps?
Yeah, hydration is number one. Hydration, electrolytes, making sure that you're maintaining your hydration is the most kind of proven thing. And massage or kind of rubbing your muscles can be helpful. There's something called a tiger tail that I like to recommend to patients with cramps. It's basically a rolling pin that's made for rolling out your muscles. It has two handles on the outside and then it has a foam on the inside and it spins and you can roll your muscles out. Some people really like a Theragun or a like a kind of um, a muscle gun that can massage the muscles as well. But really, the number one thing is hydration.
Okay. Jill asks, you work with dropped foot orthotics.
Yeah, I think probably we're talking about drop foot, which is when the foot doesn't stay in a normal position. It flops to the floor. And yes, I do work with many patients that have drop foot and work with custom orthotics. We have several companies around the region that I work with that will make custom inserts, custom braces, and will help us with that.
Great. And then Lois asks, is it Voltaren be used on the
Voltaren,
feet?
yes. And yes, it
Voltaren?
can absolutely be used on the feet.
Okay. What's that for?
Voltaren is a topical anti-inflammatory. So it's diclofenac is the generic, and
Okay.
that can be used for, musculoskeletal pain throughout the body. But yeah,
Okay.
it's fine to use on the feet. And I use it in many patients. And I also have a compounded cream that I make, that I have made at a specialty pharmacy that we use if that's not working.
Great. Okay. Shelley asks, are bunions inevitable if one has a family history of bunions? Any preventative exercises for those?
No, no bunions are not inevitable. Things that make them worse can be trauma, footwear choices. Those are the two main things. And any preventable exercise, if you maintain the intrinsic musculature of your foot, so some of those exercises on the AOFAS foot and ankle conditioning program focus on intrinsic muscle strengthening. That can be helpful to theoretically, slow any progress that you may be having or, any issues or imbalance that you may have in your big toe joint. And so that involves, like picking up a marble with your toes, doing what we call toe yoga. And you can look that online where you kind of lift your big toe, put your lesser toes down, lift your lesser toes, put your big toe down, almost like you're playing the piano kind of with your feet. Um, but those keeping the intrinsic muscles of your foot strong is important in general, and it can be helpful for lesser toe deformities and bunion deformities.
Okay. Are foot massagers helpful? It's from Lois.
Foot massagers, they are helpful. I mean, if they make you feel good and your foot feels better after you do it, then I'm absolutely a fan of it. I don't think
Yeah.
you're going to do any damage.
Okay. And here's one I'm really curious about. Laura says, what about chewing Tums for immediate relief of muscle cramps? It works for me.
Yeah, and that goes back to electrolytes. If you don't
Ah,
have
okay.
electrolytes, then um, you are more at risk of cramps. So that's why when you watch sports and it's the end of a game and it's in Miami, Florida, the guys are cramping all over the field is because they've lost a lot of their electrolytes. And so Tums is calcium carbonate. So it's simply just calcium. Then that's probably why you're noting that it helps with your cramps.
Ah, that's a great tip. Okay, Carol's asking, is reflexology helpful?
There's no medical literature to support that.
Okay. All right. Any other questions? I think you guys really did a great job answering or sending some great questions. I will say, just from a personal standpoint, there's a basic foot roller called the R3 that Roll Recovery makes. They're a company out in Colorado. It's been life-changing for me. So I will add that testimonial. It works a lot better for me than a frozen water bottle. So
Perfect.
yeah, yeah, it's really great. Um, so I mean, I know you mentioned toe yoga.
Mhm.
Like I like to stretch every morning. Do you have a recommended regimen of things you should do with your feet every morning to kind of get them
No,
warmed
I
up?
don't because, at the end of the day, if we, I'm very sensitive to that. As patients and consumers and everything, there's so many different things that we're told that we need to do. And I
Hmm.
think that if we did everything that every article we read told us to do, you wouldn't even have time to, you know, eat lunch. And so I think that if you're having pain, then absolutely, I think there's reasons to do exercises, but there's nothing I would say as a blanket carte blanche. You have to do this.
Hmm.
And, if you don't do this, your foot's gonna suffer. So I'm way more a fan of, kind of customizing a treatment plan to the patient rather than just saying to all of you on here, you need to do all these things, and if you don't do them, you're going to end up in my office. So that's kind of my thought on that.
Okay. And we've kind of covered this a little bit, but how can changes in our feet signal other health issues, like
Sure.
diabetes, circulation problems, that sort of thing?
Yeah, I think that that's a great question. And I think that when you have things like leg pain when you walk, that can be indicative of vascular issues or blood flow issues. If you have, cramping or nerve pain at night, that can be indicative of worsening diabetes or idiopathic neuropathy. And so there's a lot of things that we can pick up in the office when we're looking at your feet that may be having a more significant underlying cause. And that includes also edema or swelling in your legs or feet. When you get
Mhm.
pitting edema, a lot of I see at least one or two patients a month that come into my office because they're having swelling in their feet and ankles, but it's both legs and it's symmetric and it's pitting, meaning I can put my thumb in it and it holds the thumbprint. And oftentimes that has nothing to do with her foot and ankle. That is
Mhm.
potentially a heart issue, a lung issue, a kidney issue that we can pick up and get them to the right doctor that needs to take care of those kind of things.
Great. Yeah, I think I am out of questions. If there are any additional questions from the audience? This has been so informative. Wow, thank you so much. I think it points to the importance of, your feet, when you lose use of your feet, you know, then you lose a lot of your independence and freedom. So it's important to take care of them.
Yes, agreed.
Yeah.
Thank you all for your time. Appreciate it.
Yeah. Thank you so much, Dr. McGregor.
Yep.
I will say that the next session is on November 18th, which is also a Tuesday at 4 o'clock. The topic is Upright You. It's a balance program that LMH Health offers. And Lynette Palmer, who's a physical therapist with the therapy services group there, will talk to us. Um, a lot of thank yous and good jobs. We really appreciate it coming in on the chat. So Thank you so much. And this will be posted on our YouTube channel. I'll send it out to the group tomorrow once it's up so that you can, if you forgot anything, you can study up again. So, and thank you, Allison, as always, for lining these wonderful programs up for us.
Yeah. Thank you so much. And thank you, Dr. McGregor.
That's really
Of course,
excellent.
thanks. And I'm going to put that in the chat to Barbara.
No.
She's asking a question.
Oh,
And then you
uh-oh.
said it, yours was the R3.
The R3.
Okay,
Yeah.
I'll put them both in there.
Yeah, those are, I'm telling you, it was so great. Because I had some plantar fasciitis, and boy,
Yeah.
that has all sorts of things, different options on it for
Yeah.
your feet. Um, so highly recommend that one. You can get it online. So, all right. Well, with that, I will let you all go. And again, really, really appreciate it. Everybody take care.
Bye-bye.
Bye-bye.